Welcome, everyone, to today's session for the East Texas Geriatric Education Center Special Topics in Geriatrics series. Back in the fall, we were looking at our program planning group was trying to decide what was a good topic to cover for this year's series. And we've been doing this for a number of years, and I realized that we never run out of topics or things to talk about in geriatrics. So we decided to focus on healthcare and the older patients. A lot of this is work that is done by health professionals in our ACE unit, our acute care of the elderly unit. And we have two wonderful speakers that provide services as part of the healthcare team in the ACE unit, and I'll be talking about them in a little bit. But the East Texas Geriatric Education Center, its mission is to provide education and clinical expertise and training for health providers and students in health professions. We are funded by HRSA, and we are in our fourth year of a 5-year cycle, so we have one more year of doing this and looking forward to another renewal. I'd like to acknowledge our partnership with the Texas Area Health Education Centers, the AHEC East. They're very valuable in helping us connect with our many consortium partners that we have throughout East Texas. This is our agenda for today. We have, like I said, two speakers. We're going to concentrate on nutrition with Christopher Messenger, and then speech pathology, speech-language pathology, as in part of its role in geriatric care by Ashley Carnes. We have lots of forms and things to talk about, but before we do, I want to say that this is the fourth in a series of fourth session in this series, and we've decided to add another one in June. We were hoping to get some other materials on medication use and substance abuse in the elderly, which is becoming a very important topic, as you probably know, with the amount of polypharmacology that's going on in the older population. And we will have two speakers set up for that in June, on June 5th. Usually we have this a little bit later on in the month, but one of our speakers, that was the only day that she was available in June. And that was Dr. Catherine Cunningham, who's the chair of toxicology, and she's going to talk about medication overuse and substance abuse in the elderly. This is the purpose for today's talk, and personally I think that looking at nutrition as well as speech and swallowing issues in the elderly isn't thought of as much, especially with a hospitalized patient. And I'm really pleased to be able to maybe bring a little bit more information and awareness of what goes on in addressing nutritional issues as well as speech issues and swallowing within those that are hospitalized in our ACE unit. These are our objectives, and these are listed for our CE, which we will be providing and I'll talk about in a minute. You should have handouts on all this as well. We broadcast to 5 sites in East Texas. These are our consortium partners. Well, we are looking at the clock at Lamar University right now. That's where the camera is. But it's a fine clock. And I'm sure there's other people there at Lamar University in Beaumont. That's in the upper right. Below that is, I believe that's probably Waco, Baylor University is also our consortium partner. Up in the upper left, that large group of people, that's in Victoria College in Victoria, Texas. At some point, we'll have Stephen F. Austin University. They're not on right now, as well as Weatherford College in the Decatur area of Weiss County. For CE, we're providing free continuing nursing education credits for RNs and LVNs. This will be for 2 C&E credit hours. This is a process that you will need to follow if you want to apply for continuing nursing education credits. There's a C&E sign-in sheet. You must complete the sign-in request forms. If you go online for the evaluation, there's a link there, and you must be present for the entire 2 hours to obtain credit. Okay. And there is a handout there that provides some more information on how you could obtain nursing education credits. We have disclosures. There are none of our speakers nor our committee members have any relevant financial affiliations to disclose, and no conflicts of interest have been identified. We are offering 0.2 CEUs for social work. There's a separate sign-in sheet for that, as well as you must submit the CEU registration form and an evaluation form to obtain credit, and you would get your certificate right then after you hand in those forms. We also provide CE credits for physical therapy and occupational therapists, and there's mostly get your evaluation form done. It's an online evaluation and an online request that we'll give you once we get the credit letter and the form that they give us later on. If you have any questions regarding PT or OT, CEUs, just see me. Recently, we had a very sad loss of our GEC and UTMB family. Back in February, Adele Hertzfeld, a licensed master of social work, provided a presentation on memory loss and family affairs. She also presented with Alice Williams, who's the executive director of Libby's Place Senior Day program. On May 9th, Adele passed away suddenly and unexpectedly, and she was an amazing person, and she will be very much missed. This was her bio, her obituary that was in the paper, as well as in her memorial service at Carnes in Texas City. And yeah, so much came out during her memorial service of what a joy she was to work with and how much she cared for her patients. That was her life and her passion. And she did a lot of other things that I didn't quite know about. And I know that she'll be very much missed. She was our discipline leader for social work, for our faculty development program, as well as providing us with content ideas for social work. I have no idea how we're going to replace her, but our thoughts go out to her and her family and friends. Our first speaker today is Christopher Messenger. He's going to talk on older adult nutrition, practitioner knowledge, common challenges, and insights for improved care. Chris has considerable experience in providing nutritional consults and education to clinicians providing care to older patients at UTMB. In addition to his position as clinical nutrition manager with Morrison Management Specialists, he provides that provide the food services at UTMB. Chris is also appointed adjunct instructor at the Department of Nutrition and Metabolism at the School of Health Professions here at UTMB. He's a registered dietitian and licensed dietitian with the Texas State Board of Examiners of Dietitians since 2005. He's board certified in nutrition support clinician, and he is currently a PhD candidate at PMCH here at UTMB in Population Health Sciences at UTMB. And I am pleased to introduce and bring on Chris Messenger. Let's hear it.
Good afternoon, everyone. Glad to be here. Glad everyone who's in attendance is here. I hope I can at least have you leave with one or two things that you didn't know before. I am here to talk about older adult nutrition, try to address some practitioner knowledge, maybe cover some common challenges that we all experience in trying to address nutrition in the acute care setting, and then also maybe come up with some insights in terms of improving care. But you know my background. Who's here is a clinician actively practicing practitioner? Nurse? Nurse? In speech pathology? Nurse? And those who are not practitioners, what do you normally do? Students? What type of students? First year med students. Okay. And then I think that big class, is that all nurses students there? Yes? No? I guess maybe we can't hear them. We're not supposed to hear them anyway. So when I was asked to talk, it was supposed to be somewhat practical-oriented things that might help practitioners who are caring for patients on a daily basis. So it's somewhat oriented towards what you might see on the floors when you're going about your business, whether you're a physician or even a medical student or nurses. I don't have any conflicts of interest to declare, and Tony already covered that material. That's just a review of the objectives and hoping that you have a greater understanding of what constitutes malnutrition, prevalence estimates in older adults, some biological mechanisms. Hopefully have some open discussions about what are, again, the common challenges that we face, and then also maybe have a better understanding of what, at least for those who aren't at UTMB, what our screening mechanisms are for malnutrition and the types of supplements that we use. So I pulled a few articles on surveys that have been done to try to understand what it is that practitioners who are not dietitians understand about nutrition. And so you'll either be able to relate to this and you'll say that, oh, this is me, or this is the colleagues that I work with, or no, I know much more than that. So this was a study done in 2008 where they surveyed about 1,700 physicians and about 2,700 nurses across Denmark, Sweden, Norway. And they were asked to respond to a 32-item survey that had 16 items about their attitudes towards their own nutritional knowledge, 12 items regarding nutritional problems, and then 4 items regarding their knowledge in terms of nutritional treatment. And they were asked to provide a varying degree of they agree with something, do they disagree, do they strongly disagree, and they also had some rating in terms of things that were relevant or non-relevant, or was adequate or inadequate. And so this first figure goes that between doctors and nurses who reported reasons for having insufficient nutritional practice at their hospitals, you can see that 50% of those surveyed said it was a knowledge deficit, a little over 50%, probably 55%. Interests in nutrition, feeling that they had, I don't want to say that they didn't care about nutrition, but that that just wasn't their primary focus, was up there at 40. That it wasn't their responsibility was about 40%. The issues with documentation in terms of providing nutritional care was about 30%, and then you see time consuming and identifying which patients are malnourished. So overwhelmingly, it's an interest, a responsibility, and then certainly a lack of knowledge that was reported across both nurses and physicians. So they broke it down into those who are self-reported. They self-report their knowledge, nutritional knowledge, and they ask them, do you find it difficult to identify patients who are at nutrition risk? And in terms of assessment, that I lack the techniques for identifying malnourished patients, and then also treatment, that I find it difficult to organize a nutrition program. And as you can see, that in the first column here, where it says low self-reported nutritional knowledge, those with those questions who scored a 1 or a 2 were considered to have low self-assessed nutrition knowledge, and those who fell into the good category who scored an 8 or 10 on the questions. And so if you can look at those who find it difficult to identify patients at nutrition risk, those who say that they found it difficult clearly they know that they have a deficiency in knowledge in terms of nutrition, and it trends downwards that as you become less and less knowledgeable about nutrition, you tend to disagree less, that you don't know what to do. Whereas those who reported having very good knowledge tend to strongly disagree with that they find difficulty in assessing nutrition risk. So, this is a self-perception of one's nutritional knowledge, and clearly they associate that with an inability to identify patients who are at nutrition risk. Those in terms of assessment, and that they lack the techniques for identifying patients who are at nutrition risk. You see the same trend here. Those who have a poor self-reported nutritional knowledge based on those questions overwhelmingly agree that they lack those techniques, and I would guess that it's that lack of knowledge that is a lack of ability to perform those techniques that would identify those who are at nutrition risk. And as far as applying treatment, finding it difficult to organize a nutrition program or an intervention, again, the trend is consistent that those who have the lowest amount of nutrition knowledge, at least self-assessed, are far more likely to agree with that statement than those who have a good amount of knowledge. So, this is certainly suggestive of an issue of training. Either those who are currently teaching those medical students or residents, they themselves have poor knowledge, and it sort of trickles down, if you will, that I wasn't taught and therefore I don't know how to teach, or that those who are considered to be or consider themselves to be proficient in nutrition assessment or nutrition screening or intervention aren't involved in the teaching of those students, or aren't involved or don't take roles in which they can disseminate that knowledge to the people who clearly feel as though they're not adequately trained to do so. Here is attitudes to your own nutritional education in terms of optimal nutrition relates to or leads to fewer postoperative complications, infections, mobilization after surgery, lower mortality, pressure ulcers. That those who felt as though they had a insufficient education also did not link malnutrition with those topics. So those who felt that they had a good education in terms of providing nutritional screening, doing nutrition assessment, doing nutrition interventions, were much more likely to associate nutrition with these types of outcomes. So if you want to lead to reducing these things in your patient population, which we all do, we sort of have the, I guess if you're a nurse, you're sort of focused on things that you normally do that address this, or if you're a physician, you're focused on things that address these things. But for nurses and physicians, you're much more likely to probably ask about nutrition-oriented things for the patient, knowing that these are, in fact, linked to nutrition at the patient's overall nutritional status, malnutrition intake. And this was a separate study done in 2006, where the nutritional status was assessed by 4 trained interviewers, and this was 4 gastroenterologists and a dietitian. And they used subjective global assessment, which I can show you what that form or what that technique is. And they assessed 69 patients of a general medicine ward and determined, and they did that within 10 days. The mean age of the group that was there was 66. They found that 69% of the patients who were on the floor were considered malnourished by subjective global assessment, which for dietitians, that's the gold standard by which we can assess nutritional status in the acute care setting. Of those 69%, 30% were severely malnourished and 39% were moderately malnourished. And they went through the charts and they looked for documentation of height, weight, weight loss, oral intake, decreased appetite, all these things that you see here, muscle wasting. If any of these things were documented as being assessed by any of the practitioners while that patient was here. And what you can see is this is in terms of documentation of nutrition-related parameters, and this is not that these things exist, but whether or not the particular subject was addressed. So those who were classified as having a nutritional issue, actually designating this person as having a nutritional issue, was only 3. And as you saw, that the prevalence of malnutrition on the floor was 69%. So there was a lot of missed people. Albumin was overwhelmingly done, which I will discuss later in terms of that's being a valid measure of malnutrition. Muscle wasting was only documented in 12. The addressment of functional status was only done in 22 patients. GI range of symptoms in 43. I guess that's strongly guided by physicians being more comfortable with doing an assessment of a range of symptoms of the GI tract. Decreased appetite, oral intake, weight loss, having a weight measure and a height measure. And they made sure to point out that for all hospital admissions, the nursing intake form includes a section for recording the height and the weight. So that's mandatory on everyone who's admitted to the hospital. And yet, only 58% and 45% of patients who were on the floor after 10 days of being there had a height or a weight documentation. And so I can show you what I see, and I did I don't know if you can see this if you can see this well, but I just took randomly selected people off of the floors who were older population and looked at what if there was a nursing order for a weight documentation, then how often we were actually taking weights. And you see here, it's an 85-year-old male. He had no active order for taking weight measurements. He had a weight taken on the 1st, the 2nd, the 4th, and no weight since. So, he's been here upwards of 20 days, but we don't know what his weight's been since the 4th. 79-year-old female, there's a physician order for a patient weight to be done in the morning, starting on the 13th. There was one on the 12th, which was probably the admission screen, and there's been no weight since. Well, actually, there's a weight on the 20th, so we figured out what it was a week later. 66-year-old female, weight daily order to start on the 14th. done on the 10th, done on the 11th, not done since. This one actually pretty good, 78-year-old female, also for a weight on admission and then every morning on the 12th, 13th, 14th. We missed one on the 15th, 16th, 17th, 18th, 19th, and 20th. Now, you notice I put method here. Nurses are able to write a comment into Epic on whether or not or how they determined that weight. And certainly you can do bed weights, you can do standing scale weights, you can do Hoyer lift weights for people who can't get out of bed or stand or whatever. And most of the time we don't know how these were done. And what I guess what I struggle with often is that a lot of times this weight was done in the same day, and the person's weight varied by about 5 kilos, which is 10, 11 pounds. So since I don't know how it was weighed, I don't know if this is a report or this is a report. I mean, I have to infer that because the actual bed scale weighs 62, that this is probably some sort of measured weight, and this is probably some sort of recorded weight. But here they are up to 65.3, so we're going up. But I can't determine why is it going up? Is there equipment on the bed? Is it a non-zeroed out scale, non-zeroed out bed? I don't know. So, that requires me to, if I have a consult on this patient, try to go figure that out when I should be able to depend on the documentation. Or if you're a physician looking at this, how are you supposed to judge whether or not the patient that you have there is losing weight or eating well? We don't know these things because we are not getting weights like we're supposed to. And this is not a UTMB thing. I mean, I've talked to dietitians from all over the country over the years, and we all have the same problems with difficulty of documentation. And so, as I'll show, when we talk about what is someone who's undernourished or malnourished, weight is almost universally necessary to judge whether or not someone began well-nourished or not well-nourished, and then whether or not they decline. So the other thing is strange that the physician put in the expectation that they have a weight and that it's done daily, but there's this gap here. So obviously the doctor who wanted the weight every day isn't looking at it either. Otherwise, you'd think the doctors would be going to the nurses or whoever's supposed to be taking the weights and saying, I need a weight today, or I need a weight tomorrow, we need to start taking weight. So to me, when we talked about that previous study where it was deficit of knowledge and it was one of those was responsibility. And I think that some part of it is that because it's not a priority or a feeling, it's not a responsibility to watch the patient's weight, that it's not being looked at. Because if we were all looking at weights like dietitians do, we would have an issue that we're not getting weights like we need to. So that's just a few examples. I think I had a few more. Maybe that was it. So again, so this is the frustrations that we as professionals who we're sort of, that's our responsibility as a focus on nutrition, constantly deal with, is trying to make sense of, when we don't have records, what's going on with a patient. When is it fluid, when is it not fluid? When is it measurement error, when is it not? Was it a non-zero? All these places where there could be error. And we use weight and height to estimate BMI. We use height and weight and age and sex to estimate calorie needs and protein needs. And so when there's a lot of error built in here, it makes our estimates for our patients that much more off. Again, this is not UTMB specific. This is just everywhere I go, all clinicians that I talk to. It's a problem, and I can't. For those of you who are nurses shaking your head, what do you have a suggestion as to what you think that might be? Why?
It could be the patient's condition changed and they are no longer able to stand or ambulate to a standing scale, or they have altered mental status and changes like that. Also working in the nursing homes, weight is extremely important in our frail elderly there. And if there wasn't a weight on the chart when we were rounding, we would get one immediately. So I was wondering if you get that with your consults. If you can't figure out from the documentation what's lacking, can you get a weight when you're there doing a consult?
Yeah, we either talk to the nurse to get it or to go into the room, and we have to ask questions. Was it zeroed when they're? So a lot of particularly the older adults, they're not very good at recalling their weight history. So we have to rely on family documentation. But office visit records, since we've upgraded to Epic, it's been a tremendous resource for us because we can then go through and look at all the office visits they have with UTMB practitioners, and we're able to sort of find out what's an erroneous or there's some sort of confounding factor there that's made the weight not valid, and sort of smooth out trends. And that's much more useful for us when we then go in and talk to the patient. We can say, oh, I looked at your weight records over the past 12 months, and we see that you've kind of been sliding down, or you hit a low 6 months ago, but it looks like you've come back. And so it helps us dialogue with a patient to sort of kind of cut right to the chase rather than having to start from scratch and figure out where they've been, because the recall is very difficult for the older adult. And when I ask them, do you have a scale at home, most of them say no. So they're not self-weighing at home. They usually get weighed when they go to see the various physicians that they see. They always get their weight done, or they should always get their weight done in the office visit. But they don't always, but they sort of, I guess, feel as though I should know that, having access to their records, that if they are taking weights at their office visits, that sort of maybe absolves them a little bit of the responsibility of doing weights at home. But anyway, so moving on. Now, as you saw, the number one thing that was done or documented was that their albumin was checked. And for a long time, albumin has been associated with malnutrition, or even an indicator of malnutrition. And this was, of all the patients that were assessed with subjective global assessment, SGA-A is not malnourished, SGA-B is moderate malnutrition, and SGA-C is severe malnutrition. And there's no statistical difference across the groups in terms of their albumin scores. So as you can see, the average, and this is just an ANOVA, an analysis of variance, that their albumin was, I usually refer to 3.2, 2.9, 2.91. So you've got patients who, by our gold standard of assessment, severely malnourished, have an albumin that's not really that different, either in absolute number or in statistical sense of it being different. So my organization, in terms of the Academy of Nutrition and Dietetics, and also the American Society for Preferential and Enteral Nutrition, we have for a long time advocated against using albumin as an indicator of nutritional status. It's an indicator of inflammation. It's an indicator of stress that usually come in conjunction with malnutrition or decreasing nutritional status, but in and of itself, it is not consistently associated with good or poor malnutrition, or poor nutrition being malnutrition. So this is not a statement to say that we shouldn't use albumin anymore. I'm not sure I could probably break some clinicians' habit of using albumin or prealbumin. It has its uses, used selectively and with the knowledge of where it works and where it doesn't work, and for someone who can take a lot of other factors into consideration in making a judgment about whether or not that albumin is really acting as an indicator of malnutrition, or just this patient was ill enough to have to come into the hospital, and this is just an indicator of that illness, of that stress of chronic disease or an acute on chronic disease process. So that's just, most of the papers that anyway, so moving on. I won't soapbox on it anymore. But again, of the 48 patients who had moderate to severe malnutrition by SGA, only six ended up having a consult for a dietitian or a nutrition support team. So again, thinking about the previous article, that there's an issue with knowledge and an ability to assess nutritional status. Well, if you can't identify nutritional status or identify malnutrition, then you're probably not going to see those people as being warranted for a nutrition consult or some other services involvement who has a greater focus on addressing nutritional issues. There were 25 house staff involved in the day-to-day care for this patient. There were 17 residents. This was a study done in Canada. 15 were graduates from that school. There were 8 fourth-year med students. They had introduced subjective global assessment into their curriculum 4 years prior to this study. 7 reported hearing of subjective global assessment. 3 didn't remember ever hearing of it, and 1 thought he'd heard about it in psychiatry. So that's our gold standard method to assess nutrition, and yet even introducing it into the curriculum, these people should be that group that have been exposed to it, who should be at least familiar with it. I would say that it's troubling that some just said they could hear of it, but some of them didn't even remember being exposed to it. So I don't know if that's a failure of medical students. You're just bombarded with so much information to begin with that it became a low priority issue for you, and therefore that kind of fell off the list because it's maybe not tested extensively on any of the exams that you have to take to pass out of medical school. I don't know, but there's probably a variety of reasons as why, despite introducing that into the curriculum, that it didn't really, I guess it didn't take, if you will. So this was their responses to best measurement for nutritional status. And you can see that it's sort of very broad in terms of what their opinion was as to what the best measure would be. Weight loss, albumin, overwhelming albumin, probably why they ordered so many albumin tests. Oral intake, skin fold thick, all these things, these anthropometric measurements that we usually use to assess, body adiposity or muscle mass. None of them even said muscle wasting or loss of subcutaneous fat. So, I mean, that's again, I think that's just further evidence of a lack of knowledge on their part. Important components to a nutritional history. Everyone knows, it seemed like they felt as an oral intake history was important. Weight loss is important. So, again, it's just trying to give you a sense of what they were thinking and how that might play into their practice behavior. With me so far? Any questions so far? No? Okay.
Is the subjective global assessment in EPIC as a algorithm or tool?
No, and it's not something that I have a copy of it here.
Yeah, I just looked it up.
And as you can see, it starts off where you have all these things that you need to cover, and whether or not how you respond here determines whether you fall into category A, which is normal if you add up all the scores, and then B, which is moderate, and C. So if you say that you've had 0 to 5% loss, you put in the A category. If you say you've had 5 to 10%, you fall here. But you can see that there's a lot of things to cover, which so not only is it's our gold standard probably because it's so thorough, and that by thorough it probably means time consuming as well. And so you've got dietary intake, change, gastrointestinal systems, functional capacity, change in that functional capacity, assessment of body fat, assessment of muscle wasting, edema, ascites. So all these things are supposed to be covered, and then you come up with a score that categorizes them. And I could see how if you're not exposed to it or required to use it very often, you would forget what it is or not know how to perform it because it is relatively in-depth. And so given the number of things that physicians have to do in a day, or nurses that have to do in a day, I can't realistically see them doing this on everyone. And I don't think that's the expectation. But I think if you deal with a population such as older adults, maybe like on the ACE unit, that having a understanding of at least some of the content of the subjective global assessment, that it might make you more attuned to noticing maybe temporal wasting or clavicular wasting, or taking a look at the biceps and triceps. And when I say take a look at it, I don't just mean like visually look at it. And there are some that are wasted enough that you can tell that there's frank sarcopenia going on. But to be able to then go and look at how does one assess triceps and how does one assess that, because there's actual techniques to taking those measurements and making that judgment beyond just sort of eyeballing it, if you will. So this was a study in 2008, and they were surveyed for a few months, and they assessed the nutritional status of 395 patients by an independent observer over 72 hours, within 72 hours of admission. They did a BMI and a short nutritional assessment questionnaire, which is another type of short screening. UTMB has its own screening criteria, which I can talk about later, but there's a variety of screening tools out there that have all been attempted to be validated, but they all kind of have their pros and their cons. So if you had a low BMI or a high snack score, you had severe malnutrition. If you had a low or moderately low BMI and a moderate snack score, you were considered moderate malnutrition. So the medical and nursing charts were reviewed meticulously, and that's how they put it, for evidence of malnutrition diagnosis by physicians, medical students, nurses. They looked for reported changes in weight, appetite, eating pattern, any documentation about supplement use, nausea, vomiting, bowel change habits, height, weight measurements, any attempt at doing subjective global assessment. Then they looked at during the hospitalization, not just sort of that first window would probably your diagnosis or your assessment would occur. Did the physicians make any orders about having an intake analysis, which is what we probably usually call a calorie count? Were there any orders for supplements, vitamins, minerals, energy supplements, protein supplements, any nutrition support, tube feeding, parenteral nutrition? Was there any additional assessment done? Were there any extra height weight requests? Were there any other anthropometric measurements? Again, the arm circumference and tricep skin fold thickness, or indirect country, or bioelectrical impedance. And so they also looked at discharge, and were those who were discharged, was there any mention of nutrition on the discharge? And of the 395 patients, within 72 hours, 100% were examined by a physician. Only 15.3% included an assessment of nutritional status. Of the patients who were admitted, only 22% were examined by medical students, but 50% performed nutritional assessment. Good thing, medical students. It may be that some of those things that you can measure about nutritional status, or you can judge, or you can assess, are not as technically oriented that a full-fledged practicing physician would need to be able to do. So maybe there's a trend towards focusing on some of those easier to assess things. And 80% of patients were examined by nurses within 72 hours, and about 30% performed some sort of nutritional assessment, again, that being some of the things that we talked about earlier. So the observed 126 patients were classified as malnourished. That was the observer doing an assessment and determining the patient to be at being malnourished. Only 28 of those had a low BMI, so low BMI was not a common thing. If you think about the overall number that were malnourished, it was mostly the SNAC score that identified people at nutrition risk, which is good in the sense of that's what the screening tool is supposed to do. And that 123 of those were classified as severely malnourished. So of the 126, 123 fell into the severely malnourished basket. So this is broken out by the application of nutritional assessment at admission. So this is at admission, and then this is those who are not malnourished and those who were malnourished. And you can see that of the medical doctor, which is the dark line, medical student is the white line, and then the nurse is this gray line here, that those who document anything about a medical history parameters, which again was the height and weight and nausea, vomiting, and all those sorts of things, that if you look at those who ended up being not malnourished and those who were malnourished, the percent of times where things were documented, 19 to 20, 9 to 18, 12 to 23, you can see that as far as these things go, whether or not the patient is malnourished, the physicians seem to behave the same way in terms of documenting things like heights and weights and nausea and vomiting, but they were much better at doing assessment of physical parameters and doing global assessments in the malnourished patients. So physicians were behaving somewhat differently when they believed the patient to be malnourished, if you will, and then certainly the behavior among medical students and even among nurses. Nurses seem to be consistent across groups in terms of things that they do, things that they document, whether the patients ended up being malnourished or not. So it's just a documentation of some practice behavior. This is in terms of while they're actually in the hospital, so we're out of that 72-hour window, and now there's opportunities to deal with nutrition as it's evolving while they're here. The number of patients who were normal, or the total population, so those who had a calorie count ordered, only 13% of those who ended up being malnourished had a calorie count. Those who were malnourished, who had a nutritional intervention, which was, again, to order a supplement, to have adjunct nutrition support, maybe vitamins and minerals, only 39% had an order for one of those things. And then those who received a follow-up nutrition assessment, so maybe an order for daily weights or something of that nature, again, only roughly a third had that. So again, a large number of people who by screening tools or other more or closer gold standard tools that would determine someone to be at nutrition risk or malnourished, only a fraction are being identified as such by active practitioners, and their knowledge deficits affect their behavior in terms of identification and then acting. And this was just, so in terms of dietitian involvement, they just happened to have that in here. And so those who were well nourished, the number of times a dietitian recommended a vitamin supplementation or additional feeding, about half the time, but certainly 80% of those who are malnourished, a dietitian recommended some type of intervention. Whereas the medical physician, there's not really a whole, as you can see, it's not statistically different. So the decision to add vitamins and minerals or the decision to do additional feeding, whether it be oral supplementation or tube feeding or parenteral nutrition, was about the same across the group. So again, because if you can't recognize the difference between what's someone who's well-nourished and who's malnourished, you're probably not going to act differently. So I think that this reinforces that there's an issue of lack of knowledge rather than some sort of overt behavior, difference in behavior. So this is talking about the discharge letter. So they found 334 of the patients had a discharge note to go to their primary care provider. And of the only 2 of those notes mentioned a nutritional assessment, anything that they'd done to measure the patient's nutritional status while they were there. And of the 127 who received some form of nutritional intervention while they were in the hospital, only 27 had mention of it in the discharge note that there was a need for nutrition intervention. And then only 16 provided a plan for nutritional care to be implemented following discharge. So you've got a group of patients who are malnourished, and they go home without there being any sort of, oh, you should try to drink 2 supplements, daily for 2 weeks, or some sort of plan that the patient can execute once they go home. So they kind of fall into the nutrition abyss, if you will, that once they leave our door, you gotta, we don't have a plan for you. And then 4 had a mention of a patient needing a follow-up specifically for nutrition issues. But there was a failure to specify who exactly it was that was going to do that intervention. One of them was a dietitian, that they should go see a dietitian. So I think this is a sort of a global assessment of what the prevalence is of malnutrition in the older adult. But I think all the previous studies showed that when you do a formal assessment, or at least have the knowledge to do a more in-depth assessment, that you find a good 30 to 60% are deemed to be malnourished during their admission. But this was a collection using the mini nutritional assessment, which is a common tool used in older adults, and large sample, and that about 1 to 5% in the community were found to be malnourished or in the outpatient setting, and that 20% of those who had an M&A done in the hospital were malnourished, and that those who were institutionalized, about 37%. And that if you use a different criteria, so not just malnutrition, but a very specific protein energy malnutrition, that prevalence increased to about 30 to 65% of the studies that they aggregated to get this number. And that of the hospitalized patients, it was 20 to 60%, or 20 to 60% of those living in nursing homes. So that's consistent with all the other literature that I read about the prevalence of malnutrition in the hospital setting. It seems to fall in this band most of the time of 30 to 60%. And the varying degree is probably due to the type of setting in which the study was done, the type of tool that was used to assess whether or not somebody was malnourished or not, because again, there are a lot of tools out there, and because subjective global assessment is kind of intense and time-consuming, it's not done widely. But the M&A is a much easier tool to use. So this was a study of 47 older adults, and this is sort of getting into maybe some things that we can do while the patients are admitted. Is they looked at those who were recently admitted from home, so patients who had just been admitted within 48 hours, and then they had a control group of 106 people who were still living at home who didn't come to the hospital. And they found that those who were admitted, they found that 53% of males and 61% of females were assessed as undernourished at the time of admission, and that 65% of males and 69% of females had insufficient energy intake the month prior to hospitalization. And so what that says is that when we talk about an oral history of what have you been eating for the last week, maybe the last month, talking about those things would, if we can't do a more formal assessment, that this would give us some suggestion that if you're seeing people in the outpatient setting and you're seeing them for a cold or a flu or just routine follow-up, that when you ask a simple question about how are you eating? Are you eating less? Are you eating normally? That perhaps, and I'm not saying for certainty that's a predictor of being potentially admitted in the future, but the ease with which you can ask somebody, how's your eating been in the last month, is a short question, doesn't cost anything, shouldn't take that much time. But if you find someone who all of a sudden reports that, oh, I've just been eating nothing for the last 3 weeks, well, that's something that you then probably need to carry forward, either make a referral, deal with it yourself. But they seem to be at some degree, there's some association with poor intake prior to a hospitalization that suggests that maybe that's associated with becoming hospitalized. But I'm not making that statement necessarily. And then also they found that based on a food frequency questionnaire that vitamin mineral deficiency was below 2/3 of the RDA. So we know about things like vitamin D, vitamin E, and all those other vitamins that we find to be deficient or tend to be more likely to be deficient if you're an older adult. They looked at males who ended up coming to the hospital in the control group at home, and then females who in the hospital at home, looking at these things that we look at: BMI, skin fold thickness, arm muscle circumference, and here's albumin again. Usually gets thrown in for good measure in most studies. That you see that those who had a low BMI, 29% of those who were in the hospital had a low BMI, whereas only 5% in the control living at home population. That's pretty consistent all the way down. So those who are in the hospital tend to have lower BMI, a lower tricep skin fold thickness measurements, lower mid-arm muscle circumference, that's another measure, and then serum albumin. So that's true males hospital versus home, and then also females hospital versus home. So if we're doing these measures, if we're looking at these measures in the acute care setting, but also looking at it perhaps in the outpatient setting, again, these are things in addition to how well are you eating, are things that might be suggestive of who's likely to be at home and not needing hospitalization, and those who are likely to be hospitalized. Again, this is a continuation of, okay, so of those things we just talked about, how many had low on BMI or BMI and skin fold thickness, or 3 measures or 4 measures? And no one at home had a low of all 4. But as you see here, those who had 0 at home, 87%. 5, 3, 3, 85, 7. So these indicators, much worse. You're much more likely to have a poor value of one of these scores if you're in the hospital than you are at home. So clearly there's a difference between those who stay at home and don't have to come to the hospital for care and those that do. Energy intake, those who were at home, male, versus those who were in the hospital. You can see a significant difference in terms of the amount of calories. Those who were at home averaged about 2,500 calories per day. Those who were in the hospital were only averaging about 1,800. Those who were in the female, not a difference, 1,700, 1,600. I'm not sure what to make of this, but apparently you're more likely to continue to eat normally as a female if you come into the hospital versus you're at home. But anyway, something to think about. Usually just throw a supplement at them. Order an Insure, order a Glycerna or something, right? It's easy. We don't have to wait for our tray to come up, and they're on the unit. They're in the Omnicells. So this is a study. They supplemented 17 malnourished elderly subjects, and they had 12 healthy subjects, and they also had 6 control malnourished elderly subjects, and they followed them for 17 days to get a baseline period, and then 10 days in which they did an intervention. And this intervention was a 400-calorie, 1 cal per meal formula that had 30 grams of protein. And they want to look at the impact of this would be about 1 Insure complete, not as much protein, but about the same number of calories. And whether or not something like that, just over a short period of time, 10 days, which is long for an admission, but we certainly have plenty who stay 7 to 10 days, and whether or not something like that can impact body composition, resting energy expenditure, whole body protein kinetics. And we found that those who were supplemented had significantly greater fat-free mass gain than those who were in the controls following the study. So it's 1.3 kilos is, I don't know, it's about 2.7 pounds versus basically, I don't know, maybe 0.2 pounds. And older supplemented adults had significantly greater increase in fasting rate of protein synthesis than did young supplemented subjects, and that supplementation significantly increased protein energy intake during the day period. So that group of males who clearly eat far less when they're in the hospital than when they are at home, that might be a target population to focus your supplement ordering on, because they do appear to eat less. Those who come into the hospital tend to eat less. But those supplements are only 8 ounces. That's an 8 ounces, not a tremendous amount of volume. And if you work with older adults, the frequency with which I hear, I get full quickly, I'm not hungry, I get, there's a variety of things that all suggest that if they eat just a very little, they're not hungry anymore. They might be hungry, they eat a few bites, and then, my hunger's gone now. And so supplements are an effective and an efficient way to get a lot of calories into a very small volume. And we have supplements like the 2-cal that's 240 calories per 8 ounces, and that's roughly equivalent to 24 ounces of whole milk. So if you have someone who's dealing with having early satiation with eating, you'd want to consider those types of interventions if you want to consider adding a supplement in intervention. Net protein balance in the fed state in the older adults was positively correlated with protein intake, while the fasted state, the net balance was negatively associated with protein intake, and that supplementation significantly increased. That might be an extra slide, my bad. So they thought the 3 main effects were it increased the mean protein intake near the RDA, which is the recommended daily allowance, to moderately high. It increased the calorie intake. So you can see their control group only ate about 1,400 calories per day at baseline, and then at day 10, it really hadn't changed, which is what you want to see from your controls. But your supplementing group at baseline were only eating about 1,300, and with the supplement, they were eating about 1,700. So that's a 24% increase in total calories in a day from just that one supplement. And then also in terms of protein, there's about a 36% increase in protein for that group as well. And so I know that older adults sometimes, due to oral issues, poor history of dental care, or just loss of teeth with aging, have a lot of chewing issues, and they tend to avoid things that are difficult to chew. Well, meat tends to be one of those things. And it's expensive, and it has to be cooked. And for a variety of reasons, they tend to avoid eating things that we know to be high in meat. So supplement, don't have to chew it. You can drink it. It's high quality. It's whey and casein protein, which we know to be high quality proteins, and so something to consider. I don't want to be, I'm not advocating throw supplements at everyone, but it is what this study is suggesting. It can make a difference. It can bring that calorie and protein intake up for a relatively, low cost, if you think in terms of how much effort has to be expended to consume it. This is something, it's just sort of a mechanism, if you will, that we know about appetite of older adults, that when younger persons are presented with a single food, that they'll develop a fatigue of it. So they'll eat something, and they'll be, I'm tired of it, I don't want to eat anymore, I want to eat something else. But we don't see that with older adults. They don't see there's not a report of a decrease in the pleasantness in taste when presented with a single food item in comparison with the taste of uneaten food, i.e., that older adults fail to develop sensory-specific satiety. So if you see them eating the same thing over and over and over and over again, and you sort of go, how can you just eat the same thing over and over and over again? Well, there's something about the sensory pleasure mechanisms as we age that changes where, they can drink Ensure every day for years and years and years, or they can eat the same breakfast every day for years and years and years, and we may look at them and go, well, that's weird, but there's a change, something exists there. So when we order someone, or you tell them to go home on Ensure, or you offer, if you're seeing someone in the home environment or in the nursing home setting, maybe it will help you a little bit, maybe alleviate your stress to some degree, that you're not feeling so bad that they're drinking the same thing over and over again, and how could they just not be totally tired of drinking the same chocolate or the same strawberry or the same vanilla over and over again. So I think that's a good thing, right? And that they're not experiencing the same taste fatigue that older adults would, or younger adults would. This is the other thing. A lot of times when I write my notes for patients, I tell them if you're going to order a supplement, to order it for after meals. And the reason for that is that they show that when you give preloads, so any type of intake prior to any closer than 60 minutes before a start of a meal, that they consistently consumed a greater energy amount over the next during that day, but that they eat less at that particular meal. So there's a sort of, if they fill up on the Ensure or the 2-cal, and then you serve them a meal within 60 minutes, they're not going to eat as much of that meal. So it's really a net wash, right? You need them to eat the supplement and the meal. So if they can eat the meal and then an hour after the meal provide the supplement, that's what we want to be doing, not put a supplement in there and then, oh, lunch will be up in a minute, this will tide you over. The thing is, it does, and then they don't eat their meal. So something to think about when you make your orders for supplements, or if you know the patient has a PRN supplement order, that as a nurse, when you decide to ask them if they want that supplement or when to give it to them, that these are things to consider. We also know that there's a dysregulation of weight maintenance mechanisms between older adults and younger adults, and that we find that when older adults they're less capable of returning to their baseline weight. So if we tell them to eat a bunch and they gain weight, and we wanted to get them back to maybe they lost some weight, what they tend to do is get back to baseline and then go past that baseline and gain excess weight. If they lose weight and they continue to not eat enough to bring them back to baseline, they will just reset their baseline to a lower level and not likely be able to get back to what their previous baseline was. And if you go to any of the other presentations that go on at UTMB of all the research on muscle metabolism and sarcopenia of aging and all that kind of stuff, you know that once you lose that good quality muscle, you're probably not getting it back, particularly as we get older. So the key is to make sure that we don't lose weight. But what this is saying here is that I have patients who come in and they lose weight, and there's sort of, I guess, a feeling maybe by the family members or by other practitioners that we should make this patient gain a bunch of weight back. And you have to question with every patient whether or not that would be of any value to the patient to gain that weight back. And understand, is this person also going to be physically active while we're sort of making them eat excess calories, or if they're just going to be relatively immobile and eat all these calories, they're just going to gain body fat, but they're not going to gain any of that lean body mass, that skeletal muscle that we know is associated with, mortality and morbidity. And so just gaining weight back for the sake of gaining weight is not what we want to go for. Time, Tony?
Well, start a little bit late. We can do another 15 minutes. Can you focus a little bit less on the research that's going on, a little bit more on some clinical aspects in terms of conditions that affect, that you see maybe in the ACE unit that affect nutrition intake? Like, what happens if someone has dementia, they don't want to eat, or is there special considerations?
Given the time that we have, let me cover a few other things, because I don't think that would open a new box of things to talk about. Let me go to, some of the things that we use, and I can explain for those of you who are familiar with the nutrition screen that we have here at UTMB. Body mass index, again, is something that we look at, fairly frequently, which is why we need frequent weights and accurate heights. But we've built that into our nutrition screen, that anyone who has a BMI less than 18.5, and so this is our elements to capture those who come in already malnourished. And as you know, Joint Commission requires that every patient be screened for nutritional status on admission, and that is performed by our nurses here. And so we have I guess you'd call it a homegrown nutrition screen for when you come to the hospital. And if you were ever wondering why we put these things on there, we also calculate things like ideal body weight and have measures by which we say someone has mild, moderate, and severe. But we also have weight loss on our admission screen, and the reason why we have you nurses take weights and the computer calculates a percent for you. And that's why when you ask the patient as a nurse, what was your weight 1 month ago, and then it's compared to what your weight is on admission, if that percent is greater than 5%, the nurse is supposed to ask the patient, was this weight loss unintentional? And if it is, we get a consult. What I find is that if the weights aren't done as measured on admission and weights are done by patient report on admission, it totally kills this screen's ability to correctly identify patients who are malnourished due to a history of weight loss. I could talk about our supplements a little bit. We're primarily Ross here, but I think what's probably not known is that all of our supplements are lactose-free. They do contain, so if you have someone who has a milk protein allergy, they can't drink it, but if you have someone who's lactose intolerant, I get consults or calls saying this patient's lactose intolerant, can't eat the Ensure, or patient drank the Ensure and they have diarrhea. We thought, is it a supplement? But they're all lactose-free. So despite them looking like milk and having a consistency of milk, they are not, in fact, dairy-based. They have some ingredients taken from dairy products, but there's lactose-free. They're all kosher. They're all halal. That's as our population continues to diversify in terms of religious habits. The manufacturers have made an attempt to make sure that it's safe to give these to your patients, that you're not violating any of these things that maybe not. This type of discussion may not come up in routine medical questioning, and yet we want to be conscious of those things. If you didn't know, osmolytes are moderate calorie, low fiber, do no harm type supplement, which is what we give to most people, and tube feeding, but it's not orally palatable. 2Cal is our highest calorie formula, and again, that's 480 calories per 8 ounces. So when we were talking earlier about that 400 calorie 8-ounce supplement having an impact on protein intake, calorie intake, functional status. I put this in here, people don't know this either, is that there's the same amount of protein in every type of milk that we give. So whether it's skim, 1%, 2% whole milk, the protein content's the same. And so we do focus a lot when we're talking to patients about, are you eating peanuts or other beans or meat and cheese and eggs and all those sorts of things, to try to focus on how much protein these patients are eating. But from a calorie standpoint, if you have someone who's underweight and needs calories, you'd be talking about whole milk. But if you have someone who's obese, and we certainly have obesity is an issue all across our population, but particularly so in the older adult that are hospitalized, at least the ones that I see, that we can still get them the protein without giving them the excess calories. Now, certainly if you have someone who is not eating well, the whole thing is to get more calories, more protein, and so even though this is made up by a fat content, frankly, in the acute care setting, I'm not concerned about someone's fat intake while they're in the hospital. And that goes to another thing, that there was a consensus statement put out by the Academy some number of years ago that's saying that unless you absolutely need to have somebody on a cardiac diet or a low sodium diet or a diabetic diet, then you should almost always default to a regular unrestricted diet. Because if you have someone who's on a cardiac diet, but because of the things that are on a cardiac diet, they're only eating half of the food, then we're not taking care of the biggest issue for those patients, which is poor intake calories, poor intake protein. So unless you have a patient who is fluid overloaded CHF or COPD, or a stage 3, stage 4 CKD patient not on dialysis who is hyperkalemic or has high phosphorus, I would always recommend defaulting to a regular diet, because the proportion of the meals that are being consumed, both the number of meals that they eat and the amount of each meal that they eat, is just fractions of those meals. So they're much more likely to eat the unrestricted diet food than they are to eat something that's off a restricted diet. So when I talk to anyone on the floor about like when the geriatric fellows rotate onto the unit for a month and everyone discipline kind of gives a presentation, that's usually one of the things I always cover is, if you can order a regular diet, order it. Unless you can really say that there's going to be an issue if they have a regular diet, then we need to go with something else. There are some subtleties here I probably won't cover. There is a difference between the Ensure Complete and Ensure Muscle Health, and I see indiscriminate giving of the Ensure on the floors, probably mostly by the nurses, and that there is a reason why we tell a physician to order the Ensure Complete or the Ensure Muscle Health. There's a substantial difference in the calories. There's not a difference in the protein content, which is a good thing, but particularly for the ACE unit patients or the older patients, they almost always need to be drinking the Ensure Complete and not the Ensure Muscle Health. They're going to get the protein anyway, but they're almost always not eating enough calories. So when you make an order as a physician, and you should pay attention. So I think that a lot of times it's not distinguished by practitioners who don't know the supplements what the difference is. They just see insures, that sort of big word on the can, they grab it and they go with it, rather than noticing that there's a substantial difference in the calorie content. I guess need to make sure that Ashley has time. Questions? Okay. I'm open to comments, questions. Yeah.
You take on the floor, they take their medication use, for example.
Uh-huh.
And so you take into consideration if there's interactions with medications and dealing with that. Is that something that's pretty common?
It's certainly well established in literature the number of drugs that affect appetite, affect taste sensation, smell sensation, all those sorts of things. I was hoping to have more physicians or clinicians in here, because I would ask, and you're a physician, yes? How often do you change someone's medication regimen because they say that it's affecting their appetite, or that it's affecting, that they're having taste changes or something like that?
Not frequently.
Yeah, and I think that's an issue with also not having pharmacists available. I see pharmacists available like in the SICU, but pharmacists aren't staffed to go around and review med lists and try to find out if there's an alternative that would be just as effective that might cut down on the unintended side effects. So as a dietitian, certainly if I have someone who's reporting poor appetite, poor appetite is one of those things that's difficult to nail down as to what the cause is. But we certainly do look at medications to see if there's anything that might be like a big contributor. But I think, as you might point out, is that there's an uncertainty as to which there is even an alternative, and then there's also financial issues, and that there might be a reasonable alternative drug, but it's not covered by Medicare, it's not covered by Medicaid, or it's not a $5 a month prescription, and so it's this constant battle to try to find out how we solve that issue, because sort of the priority is, if we can't just take you off the beta blocker because it's affecting your appetite, because if you don't take the beta blocker, we have a bigger problem. It's something more catastrophic could happen. So I think that's where when we talk about nutrition having to be a multidisciplinary issue, I think that's where it really has to come in, is that your pharmacist can provide input about interactions. Dietitian can do things like subjective global assessment, because we have the time to do something that's more in depth, that we can help build into physician training, or to spend more time with physicians to sort of impart some of that knowledge gap that is talked about by practitioners and residents who clearly say they don't do these things because they don't know how to do them, or it's not my responsibility. And so it's kind of like, well, if they didn't teach it to me, then it obviously must not be a priority. Because I think if you ask anyone, is nutrition important? They'd all say important, yes. If you ask them to say, is it a priority? And if you had to put it in the top 10, where would you put it? And I think each discipline would start to say, well, these are our top 5, and this is our top 5. And so nutrition probably falls in different places based on your discipline-specific training. But I would be surprised if everyone put nutrition as a important and a number 1 priority. And because it's not a number 1 priority, where it falls, I don't know. But I think that reflects in, if we're not taking weights like we're supposed to, or as a physician and you've ordered a daily weight but it's not being done and you don't do anything about it, it's because it's not a priority, right? It's not a factor into getting you discharged from the hospital, which is kind of it's not the agenda of the physician, but it is the pressure on the practitioner to diagnose, implement treatment, and discharge. And with the length of stay of 3.5 days, there's really not a whole lot of extra time to do things. And as a physician, the primary is to deal with the acute condition that brought them into the hospital. But the issue I pointed out from the other study is that all those people who were malnourished who went home, the discharge notes from the physicians didn't say anything about nutrition. So if we're not going to handle it on the acute care setting, then it has to be handled on the outpatient setting. I'll tell you, at UTMB, we have 3 clinic appointment slots for a generalized adult patient, and that's it. So if you want to be seen by a dietitian here, You got 3 opportunities Thursday morning, and that's it. We have 177 hours worth of outpatient dietitian coverage UTMB, and 3 of that's devoted to adults. Otherwise, you have to be a pediatric patient, or a renal patient, or a transplant patient, or at Combs for weight loss bariatric surgery. So,
You got your work cut out for you. I know that.
oh,
It's very, and there's other groups that may have a little bit more availability.
Sure.
for
So,
dietitian.
what I think is
Wrap it up.
that further, I think, highlights where in terms of how we feel that it's a priority. If you feel it's a priority, then you have the structure to manage that, and I don't think that's present. So, thanks.